Am, Hola, buenas tardes. ¿Se escucha bien? ¿Se escucha bien? Colegas de informática, ya estamos en Zoom. ¿Ya abrieron? ¿Ya? Then I will speak in Spanish to introduce you because I think that I cannot say how happy I am in English for having you here. So I really want to use my language to say que estoy no contenta ni feliz, sino aún más que eso, de tener al doctor Dan Kass con nosotros. Dan voy a empezar por lo que se puede leer en Internet. Es vicepresidente de Vital Strategies. Y Vital Strategies es una organización con un compromiso en resolver problemas ambientales en el mundo increíble. El compromiso es con resolver, utilizar la investigación para resolver problemas, y Dan es vicepresidente de esa organización. Por supuesto que su experiencia como científico del área ambiental, de la epidemiología ambiental, es gigantesca, y ni por mucho pretendo leer un resumen curricular de Dan, pero sí les quiero decir que gracias a la colaboración que tenemos con Vital Strategies y en particular con Dan, obtuvimos el financiamiento para volver a medir plomo en sangre en la ENSANUD 2026, y eso lo hicimos por el inmenso apoyo que nos ha dado Dan. Lo intentamos el año pasado y fue difícil ver que no lo conseguimos en tiempo, pero ahora sí lo conseguimos en tiempo. Dan nos ha apoyado como grupo de investigación muchísimo, y esperamos que la ENSANUD 2026 sea el inicio de muchas cosas más con miras a resolver el problema de la exposición a plomo en México. Entonces, no puedo decir que estoy feliz, sino lo que sigue, y muy contenta de que Dan nos dé un seminario hoy. Muchas gracias a todos y todas por venir de manera presencial, y quienes no pudieron, que estén por Zoom y por otras vías remotas que nos estamos conectando. Ojalá que disfruten tanto el seminario con todo el cariño que lo preparamos para ustedes. Thank you, Dan.
Gracias. Con su permisión voy a hablar en inglés porque, como estaba diciendo antes de la reunión, hablo, pero a veces necesito como 20 palabras para decir uno que no conozco. Entonces, okay. ¿Me escuchas? Okay. Thank you. I'm so happy to be here. I want to just say to the team here at NSAP that this brief collaboration has been so rewarding. We haven't really done anything together yet, but I'm really excited about the possibilities. And I think the most important thing I can say is not that I come here in any way as an expert. You have some of the best minds in the world working on all kinds of issues here, but in lead. If I really bring anything at all, it's a sympathetic ear to the challenges, but also the opportunities of working in governmental ministries. The middle part of my career, I spent heading environmental health for the government and the city of New York. And I loved that job. I mean, it was the best job in the world. And I appreciate so much the value of brilliant minds and creative thinkers and dogged dogged advocates that sit inside government, knowing the challenges, but also playing the long game in terms of strategy. And I know that that's exactly what is happening around the threat of lead exposure in Mexico. This is not something that will be solved quickly, but it isn't something that's just beginning either. So I'm, so excited about the potential to learn from from your team, Mara, from all of you here, to add what value I can. Hopefully the most important of which is access to a donor that is very interested in seeing Mexico advance its work on lead poisoning, and to really be a beacon for, if not just Latin America, for the world. So I was asked to maybe not talk so much about the details of lead poisoning, but to maybe bring a perspective about from a global perspective about what's happening, what's going on, what are the opportunities going forward. And this talk will basically cover some of what I've learned in beginning to do work globally on lead, transitioning from overseeing the lead poisoning prevention program in New York City to the work at Vital Strategies, trying to support other countries' early efforts to address lead poisoning. So let me just say a couple of words about my organization. I'm not here to advertise it, but we're, as Mara has said, we're a global public health organization. We work all around the world. Our model of work, which I'm proud to say, is basically that whenever we get funding from a donor to do work, the vast majority of that funding pays for staff to sit in ministry or departments of health, or if it's a program, say, on road safety in a ministry or department of transportation. Our approach is basically that we add some technical value, but what we really want to see happen is for all of any of that work to really sit in government and not do that. Our lead work is now expanding quite dramatically, and in each of these countries, we use our funds to hire staff locally to sit in the ministry or the institutes of public health, to design and to implement the work, to evaluate it. And we serve as kind of a fiscal agent, because it's often much easier for us to buy things or procure things than it is for government. So that's how we do our work. And so far, the collaboration with you has been just procuring equipment on your behalf. So this is what I'm going to just briefly cover these sort of topics. A quick reminder of, again, from a global perspective, what the impact on children and adults are. Some of the challenges that all of us need to try to overcome, both at a global scale, but also at a country scale, on dealing with the limited data that we have to describe exposure, to understand local sources, because they vary so dramatically country to country and within country. The absence of surveillance systems. And then the real challenge we have, which is all of you know so deeply, which is that we in public health assume a degree of responsibility for exposures, activities, industries, commercial activities that are not in our control at all. And this leads to public health system paralysis when it comes to a lot of environmental health issues. And this is one of the things that we're going to really have to overcome if we're going to try to tackle lead poisoning. So I'm quite sure most of you are very familiar with this, but let me just say a couple of words at a global scale about this. Estimates currently are that more than 900 million children, about a third globally, are exposed to levels of lead that the World Health Organization describes as worthy of clinical intervention. That's 5 micrograms per deciliter, which is, I think, how you're measuring it in Mexico as well. So I'm an older person at this point. I might be the oldest person in the room now. And my blood lead level, though not measured when I was 5 years old, was probably at least 15 micrograms per deciliter, and not because of horrible circumstances, but because that was average at the time. So you can see, that's not what we're really talking about, but we've learned since then that very low levels of exposure really do matter. And if you look at this curve, this one shows the two lines. what is the relationship between blood lead levels and the number of IQ or intelligence points that are reduced on testing. IQ is not the best measure of cognition, but it is sort of the global gold standard, and so it's a helpful, it's a helpful indicator of cognition and future cognitive capacity. And then about 30 years ago, we thought the line looked like this, where for every increment of lead, there was a linear relationship, so that the IQ would just drop and drop and drop about depending on the level. And if you look at sort of what my exposure was at this point, and when I was a child, I would probably have lost about 4 IQ points, which is of course preventing me from, greatness. But what we've now learned from multiple studies, and I have to admit I was skeptical at first because of the potential for residual confounding, but it's very clear at this point that the steepest part of the curve is actually in the lower exposure levels. And that is a call to action. That means that no matter how much benefit we see globally from overall declining lead exposure at a population scale, because we've gotten rid of lead in gasoline, that's the major driver, we still have to pay a lot of attention to this, because when we think about this at a population scale, we are talking about a significant shift of the IQ normal curve this direction, which we never want to see. And this just demonstrates how big these economic impacts are when you translate into productivity, lifetime earnings, health decrements, all of those things from the relationship to IQ. The global scale is quite dramatic. What we have learned a lot, though, over the last 20 years in particular, and probably the best epidemiology on this has emerged in the last 10, is that adults are not immune to the effects of lead. It's funny because lead was first identified as a toxin because of lead workers more than 1,000 years ago. People who were working directly with lead were suffering. It was observed in ancient times that they were suffering seizures, strokes, early death. We've paid attention to some extent about workers, but we haven't paid attention at the global level to the cost to adults. And the new estimates suggest that between 3.5 million and 5.5 million premature deaths occur each year globally from cardiovascular disease. Now, where does that fit in the scheme of things? That's more than some of the worst infectious diseases put together, HIV, deaths from HIV, tuberculosis, for example. It makes it the third, depending on the country, it makes it the third or fourth leading cause of cardiovascular mortality. And that's stunning. It's not entirely clear what we can do about this, because the research is not clear how much of that is mobilized lead as people age, how much of it is chronic exposure, how much of it is early exposure. But what it has done is mobilize forces in the world to pay attention to it in a way that just focusing on children has not. And this, just to point out, when I talk about mortality, that's bad enough, but when we talk about disability, and many of you are probably familiar with this term in English, I don't know how it translates to Spanish, DALYs, the disability adjusted life years, it's really quite an astounding annual number. And almost all of that is from cardiovascular disease outcomes. You can see that's the blue, the orange is the childhood cognitive impacts. Whoops. And then lastly, I don't know how well you can see this. You can turn down the lights. People don't need to see my face. It's more important to see the screen. ¿Puede bajar los luces? Mejor. Gracias. It's not, none of the mortality or the DALY data really captures some of the other things that we know about lead. And while these charts are association, they're not causation, they still are illustrative of some very important patterns that we've seen, which is that as lead levels which in gasoline, which is the blue on the top, as that changes, so too did violent crime rates in the United States. As same experience with rates of robbery. And over on the right, that shows the total production of leaded paint, and you see a very similar relationship to murder rate. Again, I don't want to overstate the causal nature of this, but these are the sorts of associations that offer enormous promise if we can do something about lead going forward, especially as you think about the fact that lower levels are steepest on the IQ curve, and that is a marker for future potential rates of antisocial behavior. So this is really good news. This is the chart. I've said already, and I'll say again, that surveillance systems don't exist in most countries. We don't know what the distribution of blood lead exposure looks like in most parts of the world. Mexico is really quite unique in Latin America for having done this kind of work for as long as you have, but in most parts of the world, it's not. And so this investigator basically compiled what were, valid, potentially representative studies of subpopulations in mostly high-income countries centered in Europe and Central Europe. And you can see these trends dating from 1974 converging toward 2020, where the average level has dropped overwhelmingly. That's really great news. But they're not declining everywhere. And while in the absence of good local data, we who work at the global scale depend on modeled data. And the best modeling is happening right now at the Institute of Health Metrics and Evaluation, EHAMA, at University of Washington. And this shows you what, based on modeled results, we expect average blood lead levels to look like. And so I can point here, this is where most of those studies, the previous slide, come from. And so you can see that they reflect these low levels, but all through the equatorial world and the Southern Hemisphere, levels are quite higher. More mixed news from a global scale. One is that there is no lead in gasoline, which is really amazing. The last country to prohibit it was Algeria in 2021. But most of the world that you saw in the orange and red colors in the previous slide, most of those countries were late compared to higher income countries to remove lead from gas. And most of the global curves are attributable, the change in the curves is attributable to a lag between that prohibition and when it's measured. And I would be remiss if I didn't say that one of the principal reasons why it took so long in so many countries was the incredible force of the petroleum industry and the companies that were making tetraethyl lead. They lobbied, lied, bribed their way into the gas supply for more than 20 years longer than they should have in many countries. Now, those are some of the good trends. One of the negative trends is that one of the potential important sources globally for lead, especially in low-income countries, is electronic waste, both because they produce it, but because it's a dumping ground for higher income countries. And so you can see this rapid rise in the production of e-waste at a global scale. And we are at the steepest part of this curve. It's only going to rise. This chart represents both production and, in this sort of faint blue line, the recycling rates. And you can see right over here that the two countries that are responsible for well over half, or I think even close to 70% of all e-waste production, have some of the lowest recycling rates. Now, where is it going? some of it is being dumped illegally and inappropriately. It's ending up in landfills. It's contaminating water, but a lot of it from China and from the United States is also being exported in places with even fewer controls. We've learned through the work of several organizations and local studies that lead sources vary dramatically by country. You know, in the United States at this point, really the only remaining source of lead that really is influencing population level exposure is leaded paint that is already in place, peeling, chipping damaged in walls and exposing children, and then some occupational work. But in much of the rest of the world, we've seen these sources really emerging as probably some of the most important. First is lead acid battery recycling. I imagine for many of you who visited pueblos across Mexico, you've seen this kind of informal battery recycling where the lead from a tired, no longer chargeable automobile battery is extracted, it's melted, smelted, formed into lead ingots, and sold back to battery manufacturers or for other uses. There are safe ways to do this and through formal regulation, but in much of the world, at least half of all lead battery recycling is done informally in the backyards of homes in a facility located in a densely populated community. And you can imagine the kind of deposition that occurs of lead dust from that, as well as occupational and home-based exposures. I've mentioned e-waste recycling. We continue to extract lead across the globe at record rates. So even though lead recycling is making a big difference, the demand for lead in industry, for electronics, for other things continues to grow as populations grow. And so we still have the problem of lead extraction, both primary and as a secondary contaminant from other mining operations, so like gold and silver, which is an issue here in Mexico as well. Lead paint, only about half of the countries in the world prohibit lead paint to a level that is reasonable, 90 parts per million. But a lot of lead paint is still in place. And lead paint was used both for household paints, but also for commercial paints on infrastructure. And it's very commonly found, for example, on metallic as a bright color on metal, and that characterizes a lot of playgrounds, for example, around the world. Lead and ceramic glaze is really important, we know, here in Mexico, but not just Mexico. Lead is used as a tint, as a colorant, or as a finishing product for a lot of materials. And one thing I should note besides ceramics for cooking is that we're very concerned about the informal production of aluminum cookware. In many countries, those are produced kind of in a similar fashion as lead as batteries are recycled. Backyards, they collect any kind of metal that is scrap, no matter what the contaminant is in it. And then finally, in much of the world where we're working in South Asia, in particular, and certain African countries, lead in spices is a big deal. It's prized by unscrupulous producers and vendors because it's both bright and colorful. So for a spice like turmeric, lead oxide, mirrors that color really nicely, and because it's so heavy, it adds weight. Especially to ground spices. So this is quite an important source. These are not intended to be universal, but these are some of the leading ones we're seeing globally. So again, I was asked to sort of just try to bring a global perspective to this, and these are some of the things that are challenging us at a global level to make really significant advances. One, we continue to suffer from the pace at which tetraethyl lead was added to gasoline. Should never have been there. There was no good reason for it. It was marketed sort of very, very strongly, first in the US, then globally by the manufacturers of it. But we continue, it takes as you can see from like the United States curve of lead, it takes 20 to 30 years to really see the full benefit of that prohibition. As I've said, we have very, very limited data at a country level. And while I really love the modeled international data, we use it all the time. It has been very effective with donors. It is not effective in moving local and national governments to act. You know perfectly well, you exist in order to generate local data for action, and without it, we have a very hard time expecting governments to act on sources. We also don't have good representative data, and it's a very we know how important in this room is. How important surveillance data is, at tracking things longitudinally, evaluating the impacts of intervention, targeting subpopulations, whether geographic or ethnic or age groups or sex, is so critical for how we manage such scarce public health resources. And without representative data, there's just no country can figure out what's happening, what progress they're making, and where to target. I've already talked a little bit about the limited public health system engagement, but it's not just that. What we in public health, I think, rightfully think of ourselves as sort of on the leading edge of pointing out social ills. The solutions rarely lie with us, but we motivate and we generate activity in other governmental institutions, in ministries of environment, transport, industry, finance. Where do they invest? How do we reduce exposures? And without public health engagement, we're really lost there. And without public health as a convening entity for that kind of interministerial whole of government activity, it's very, very hard to see actions. Much of what I've talked about depends on being able to measure. And Mexico is in a much stronger position than most of the rest of the world. I'll give you just a couple of examples. In Ghana, in Africa, where we're beginning to work with the government on lead poisoning prevention, we collected all of the lead exposure data that had been reported by laboratories across the country. And over a 15-year period, there were 400 tests. That's just, you can't do anything sort of at that level. You can't detect, you can't measure, you can't characterize, and you can't guide any individual's health intervention that's necessary on their behalf. So we really need laboratory capacity. And one way to overcome the absence of good clinical labs is to use point-of-care devices for lead, which I know that Ensanos has used and will continue to use to test capillary blood. But this is an imperfect solution. One, because its limit of detection is really quite high relative to population levels. It's 3.3 micrograms, and in some countries, most of the population is still below that, even though those are lead levels that matter. It's an imperfect device. One thing that's exciting is that some of the new money, which I'll mention in a moment, is going toward trying to fund the development of additional point-of-care devices that will be even more accurate, have a lower limit of detection, be quicker, and potentially test other heavy metals as well. And then lastly, just, we, across the world, we don't have good clinical management of lead. We don't have clinicians engaged in this. And if we think about, clinicians, and I'll mention more in a moment, but if we think about clinicians, think of all of the things in our field that we've been able to identify as critical priorities for longevity, for quality of life, that began with clinical interactions. And think of the role that clinicians play as trusted sources in mobilizing public policy. And so without clinical engagement, we again are really disadvantaged. Let me mention a couple of things that are happening globally, and this relates to, I know that some of our real hopes and dreams for Mexico in this next round of the representative blood lead surveillance work. It is very challenging to identify the sources that matter, and it's very challenging to attribute from a percentage basis which sources of lead are responsible for what proportion of blood lead levels or cases of exceedances of standards or guidelines. Across the world, there's activity going on to try to do that, and they're happening sort of in these ways. One, market screening, and I know that this is something that's already been done in parts of Mexico. It's very much part of our current proposal, is to take a look at globally or from local small studies, which products have been implicated, and then ask the question, what is their prevalence? Are they sold everywhere? If we were to try to go after those sources, where would we concentrate first? So that those kinds of market screenings will look at spices, they'll look at cookware, they'll look at pottery, they'll look at the sale of traditional medicines. They'll look at, this is a big issue in Africa and South Asia, they'll look at eyeliners and lipsticks and cosmetics. They'll look at traditional cures that pregnant women take, and they'll buy them, test them, and evaluate what percentage are contaminated and where they're located. Hotspot analyses. This also has been done across Mexico, is what are lead levels where we know there are lead sources? And those are really important things to determine, both for characterizing population risk, informing them, intervening on the source itself, and potentially cleaning up where appropriate. Home-based assessments. This is where, government organizations, advocates go into the homes of people and they evaluate not just what's in the market, but what's actually in the home. And one of the real potential opportunities that we're seeing across the globe is to pair this with representative surveillance work. And so we are able to identify not only, are these products that are sold in markets in the homes, but are they more prevalent where we're in children where we're seeing higher blood lead levels, or in adults where we're seeing high levels, and which products are in the home. Case investigations is something that is so valuable in places where there is a strong clinical engagement with lead. So I can speak for New York City, for example. In New York City, there is near universal testing of children below the age of 3. So our spotty public funding of medical care called Medicaid, it requires a test for children under 3 at least once, and it's covered by other health insurance systems as well. And so we know the blood lead levels of almost every young child in New York City, and where the levels are really high, we can actually, because we have a reportable requirement, the law says any lab that tests for blood lead anywhere in the country for a child in New York has to deliver those results electronically to the city of New York. We look at those, and depending on the year, we have a different cutoff point, but we will go to that child's home and investigate the sources of lead. And that's been an important way to discover not just things like peeling lead paint, but also the presence of mostly imported products that have poisoned a child or poisoned a pregnant woman. There are some studies underway right now on cookware. We know that lead is a contaminant in aluminum cookware, but we don't really know yet how important it is, how much of it actually comes to the surface during cooking to be able to contaminate food, and if it does, under what conditions. So that's a very exciting set of work that's happening globally. There are organizations out there that do really good jobs at supply chain tracking. Again, in the service of trying to understand how important and widespread a source is. So one organization, for example, called the Lead Exposure Elimination Program, they have been focusing for years on lead paint, along with the United Nations Environmental Program. They do a tremendous job finding lead paint in a particular country, figuring out where it's manufactured, where the pigment is coming from, whether if the paints are imported, which country they're coming from, and thereby both inform what has to happen from a legal perspective to be able to go after them, but also to plead with foreign governments to do something about their export trades. Another way that we're trying to advance this work globally, I mentioned how hard it is to specify which source matters for which person or which sources matter for even at a population level. We assume that if it's lead, it's bad, but that's not the same as saying that it is responsible for, say, half of poisonings. This is important because environmental ministries already suffer from an absence of enforcement in most parts of the world. And so if you're pleading for governmental action to improve enforcement, it would be very helpful to know what to focus on first. Pairing isotopic analysis with, you take someone's blood lead level, send it to a lab. You pick out the sources you think might be important, whether it's food, spices, paint, etc., soil, dust. You take all of that, send it to the same lab. They do an isotopic ratio analysis, and they compare the ratios of different lead and other isotopes in the blood and in the set of products to identify which are the closer matches. This enables us to really estimate the attribution of one source to an actual exposure. Now, the challenge, of course, is very expensive. And there are, in the countries where lead problems are worst, they are the least likely to be able to have the laboratory equipment, capacities, and skills to be able to do this work. And then lastly, I don't want to underestimate the importance of representative surveillance and survey work. The work that you've been doing over the years here and that we are doing at Vital Strategies in other countries to ask questions while testing someone's blood about their risk factors, both demographic, geographic, community, personal, occupational. These are really important. And while they're imperfect for quantitative attribution, they are really important for identifying potential sources and their importance. I wanted to just share some of our work just very quickly to just give you a flavor of the work, how the work that you're doing here in Mexico both has informed work globally, but also resembles work that's happening elsewhere. We worked with local government and research institutions in the state of Bihar in India, which is in the northeast of India, to identify what is average exposure and what are some of the risk factors associated with it. Just to give you a flavor of these levels were a bit higher than the global estimates were. Again, emphasizing the importance of local data. 90% of children and 80% had lead levels exceeding 5 micrograms per deciliter, and 20% of children were exposed above. That's a very high population exposure in this state. And some of the risk factors associated with it from survey and from home-based assessments were living near a lead-related industry. Interestingly, using a lightening cream, which we know has mercury in it, but we didn't know has lead, and so we're following up with purchasing lightening creams to see if it's true or it's a confounder. Carga, or eating soil, the use of a particular set of traditional eye cosmetics, which is in this part of India is used not just by adults, but on young girls as well, and families with lead-related occupations. This also used lead care too, just like you do. And then in a state in southern India, we did the same thing, where we looked at blood lead levels, and the blood lead levels were quite lower here. But still, you saw that 39% of children exceeded 5 micrograms per deciliter. And just for a point of comparison, in the United States, that percentage is 2.5%. So 2.5% in the United States versus 39% in Tamil Nadu. And you can imagine the amount of money that continues to be spent, on lead evaluation in the United States at that level compared to a place like India. And so the injustices and the inequities are really quite apparent here at a global scale. And then I just included this one other chart over to the right, just to show you how important the region or the district was. So within a state in India, there's wide variability in geographically in exposure. And this is the first time anyone has been able to demonstrate this at India, because all of the prior work was only resolvable really at the state level or even national level. So that's so important, and it argues for improved sample sizes and better sampling schemes to be able to really characterize this. I'll skip that slide. So let me just talk about a couple of other things from a global perspective. I've mentioned how important public health and clinical health engagement is. We're not in a good place across the world for this. About 4 years ago, the World Health Organization for the first time issued clinical guidelines for lead as a model for countries to adopt and to adapt. But we have to acknowledge right at the beginning that there's really a limited role for doctors. One is that there's not much besides eliminating the source and counseling patients on how. There's not much that can happen at blood lead levels that are typically seen even in high blood lead level countries. Chelation therapy is really indicated only for the highest level, and even then brings risks, especially under conditions where the source continues to be, you haven't eliminated the source. But even with this limited role, there is an enormous lack of guidelines in terms of engaging clinicians. In most medical school curricula around the world, there is no environmental health training. And if it is, it's very rudimentary. It's measured in hours rather than units or courses. Lead is not a routine part of training across the world in medical schools. And in many countries, there is no continuing education. Even when there's a requirement, there's no available obvious way to train an existing clinical workforce up on lead. And then finally, chelating agents are largely not available. They're not part of essential medicine lists in most countries, or where they are approved for other purposes besides lead. I know the text is very small here, but I just wanted to highlight some of the important work that's happening globally that I'm proud to be involved in around clinical management. So the WHO global framework has recommendations of clinical activity for all age groups, and then for other populations, children at various ages, pregnant and lactating women in particular, and the guidelines differ as they should by those things. Every recommendation that WHO makes is based on what the blood lead level is. Now, that's an obvious problem because I gave you the example of Ghana, where there are 400 tests over a 10-year period of time, or in most of the world where a minuscule, insignificant number of people are being tested for lead. And so what is the value of a clinical guideline when you don't know what the blood lead level is? And this is a huge challenge. The absence of sort of testing will inhibit countries from adopting these guidelines, because they rightfully ask themselves, of what value is this when we can't test children? So we began an approach in collaboration with the Peruvian ministry several years ago, where we tried to grapple with this question in a low resource setting. How can you use surveillance data, if you have it, to predict the blood lead level of a child? Now, the short answer is you can do it with questions that are in fact predictive, or together as an index or through multivariable analysis, are predictive of blood levels, but has a very wide margin of error, as you can imagine. But it takes you quite a bit further in terms of being able to, as a clinician, say something. And so in Peru, we piloted this program where we looked across 3 domains. One was clinical suspicion, but as many of you know, as physicians, you rarely, if ever, see obvious symptoms from even high levels of lead exposure that are not easily attributable to other causes as well. But you can have clinical suspicion, developmental disorders, anemia, neurological symptoms. Couple that with individual and family risk factors that you can easily determine in a short clinical interaction, whether they have, if it matters in a country, whether they have peeling paint, what is the occupation of the parent, what kind of foods are they consuming, and potentially what kind of cookware they're using. And then finally, a vulnerability score, which looks at a community level, what do we think the average level looks like in that community? What are the housing characteristics in that community that might be predictive of higher or lower blood levels? And in Peru, this is scored. And depending on the score, that dictates the follow-up action. The most important one of which is counseling, but the other one that matters is, given Peru's ability but limited lab capacity at this stage, only those at highest suspicion would be referred for lead testing. And that's a valuable approach. It's imperfect, but it is one way to think about how to do this. Now, we did this before the WHO issued its own guidelines. And since then, we worked with UNICEF and the Ministry of Health in Indonesia to adapt the WHO guidelines. And there too, we proposed and they accepted a kind of risk assessment as first interaction rather than the presumed blood lead test. And here you can see that there are scores across, different domains. So we think that greater risk factors predict greater blood lead levels, and the number that's in each of those cells refers to a particular set of interventions that belongs to that level. And you can get to that without a blood lead level. I'm going to sum up just a couple of things here. Another challenge that we're facing globally is that even as we begin to think about collecting improved data on both sources and on exposures, we continue to face these challenges about moving that data from evidence into policy for many of the reasons I've already described. So this continues to be something that we really have to address. Lead is not the only result of a fragmented government focusing on particular priorities. We know how challenging this is. We know how under-resourced environmental health is within public health systems generally. And these are challenges that we're just going to have to try to overcome. But, when I make my first pitch to ministries of health around the world to pay attention to this, one of the things I try to overcome is the skepticism that there is something that can be done and it'll make a difference. And this chart and the next just shows the degree to which policy interventions are critical, necessary, and most predictive of improvements in exposure. This is a chart of the United States from the year 1972 all the way through, I think, 2012 in this case. And it shows average blood lead levels in children under 5, the decline, and which policies have been associated temporally with each of those things. So this first one is getting lead out of paint. This one is the formal phase down of tetraethyl lead in gasoline, which was completed here, somewhere here. in this period. You can see other ones. This is our Safe Drinking Water Act, where the public water supplies only could be reach attainment at lower and lower blood levels over time. It set a path for that. So these are just examples in the United States of how policy, framed and led to these really quite dramatic, reductions, so that the average level of blood in children now is less than 1 microgram. This one, though, is from China, which in some ways has more sway in some ways, because China, over this period of time, has not only tackled lead at least to a large extent, but has tackled a whole host of other social ills as well. From during this period of time, average income has grown, general longevity and life expectancy has grown, and here each of these refers to a particular regulation in China that has preceded many of these declines in blood levels across the country. And one feature of China regulations, arguably even more so than in the United States, certainly the United States of today under our current administration, is that there's near universal enforcement of these regulations. And so it makes a huge difference. So where are we, like around the world right now on lead? Well, one measure of potential progress is how much are we investing in lead poisoning prevention? We don't have a figure for how much countries spend, but we know it's very small. But we do track global giving on lead. And as before last year, just $15 million in philanthropic funding on average was dedicated to lead poisoning prevention each year. But the next year, things just changed overwhelmingly. And by this year, we'll have about $500 million US pledged to work on lead poisoning prevention over the next 5 to 7 to 10 years, depending on the donor. And what made the difference? It was the work of global advocacy organizations like Pure Earth, which I know has worked in Mexico in the past. It was the work of investigators, dogged investigators, doing the work of estimating the mortality from lead and reaching the point where those numbers we had confidence enough in those numbers to start sharing them globally with donors, policymakers, et cetera. And so we're proud at Vital Strategies to be part of the Bloomberg Philanthropies Initiative, which is a $250 million initiative in 9 countries. We're working on the surveillance and the clinical management side of it, as well as a few other things. Coefficient giving, for those of you who may not be aware, we have issued a proposal to tack on to the Ensenut blood lead survey, some really important and a very innovative source identification work that you have come up with at INSP. We're waiting to hear about that, but they have pledged globally quite a bit of funds to support work going forward. And then there's also this thing called the Audacious Fund, which is, it's how do I put this? You gather 3/4 of the billionaires in the United States in a room, and you pitch them a handful of ideas, and then you reach into their pockets and pull out millions of dollars. So that's a new fund that's available for this as well. And so we're going to see, at least by the end of next year, we're going to see representative surveillance in 25 countries, which is really extraordinary advance. We're going to see source characterization in at least 25 countries. We'll have clinical guidelines either passed or in development in at least 13 countries, and maybe more by the end of 2026, we hope. And then we'll have regulations in process across the whole of Africa through this really important work of LEAP. So this is what donors have been focusing on. They're sort of all of the gaps that I've described up till now have become the basis for foundation funding, with one important exception, which is public awareness. There's still no donor that is tackling the problem of how do you inform the public about this. And this is so important because we know that the difference between that pathway of evidence collection to policy to enforcement at every point along that way depends on public pressure. And you can't have public pressure without public awareness. So this is one of the big gaps that we're going to continue to see. But these are the things that are being worked on, and I've talked about most of them. There's some really good sort of research around sort of cost effectiveness of different remediation interventions. Some, as I've mentioned already, point of care technology improvements. There's continues to be research, very uncertain results about what do you do about adults with chronic exposure? How do you reduce their cardiovascular outcome risk? And there are a couple of studies in the United States. One offered suggestive findings that prophylactically chelating adults after their first heart attack reduced their risk of mortality. But a subsequent one has looked again at a broader population of people with cardiovascular disease and has not found effects. So there's more work that needs to be done, on that kind of thing. These are some of the global organizations that are really, sort of they're funding recipients from some of these donors. I've mentioned a couple of already, but I don't want to leave the impression that my organization is alone out there working on this. There is a growing global community of organizations, but also importantly, investors. And I think one of the really exciting things that I hope to see over the next couple of years is that teams that are working in government become part of a global community if they're not already, that really share successes, challenges, findings, techniques, and resources. And I usually really like to lead on that optimism side, but the reality is that those of us who are working in public health, and I'm not going to speak for Mexico, but I will speak for my own country, are really in very challenging times. We are under-resourced to start with. We are underpowered to start with. But now we're seeing, not just in my country, but we're seeing evidence of this elsewhere. We are being doubted. There is a tremendous amount of misinformation that travels much farther and wider than our communication skills typically do. And at a global scale, we're seeing the threat of competing resources being able to really address this issue. The ones that I think in many of the countries, especially in the sub-Saharan African countries that need so much of the work, and in some of the South Asian countries, we are seeing not just competition for public health resources, but we're now seeing public health dollars being diverted into military budgets. We're seeing public health dollars being diverted into making up the difference in the loss of US and European aid for essential life-saving treatments, especially, in HIV and tuberculosis and, that kind of stuff. So I want to be very optimistic about this, but I also understand that we're really, it's not a good position to be dependent on philanthropic funding. So it's so important for us to do everything we can to move as rapidly from evidence into policy. That's it. Thank you very much. Oh, use this one.
Thank you, Dan, for this wonderful presentation. Quiero agradecer especialmente al doctor Sergio Iván Valdés y a la maestra Ana Lucía Rosado, que vinieron de la Secretaría de Salud, especialmente a este seminario, por la importancia del seminario. Y no sé, Sergio Iván, Ana Lucía, si quieren hacer algún comentario, si se esperan a las preguntas, ustedes díganos. Nos encantaría escucharles. I think that it would be better.
All right. Thanks, Zen.
Podríamos decir una cosa. A los colegas que están por internet, tenemos el chat inhabilitado, pero hay una sección de preguntas y respuestas en el Zoom que está abierto. Por favor, pongan sus preguntas ahí y en la siguiente sección del seminario las abordaremos. Perdón por la interrupción.
Gracias, gracias. That was a wonderful talk. Thank you so much. The reason I'm here is vast and deep as your talk was. Day one, when I joined the ministry with Dr. Krasinovich, the current secretary, he gave me 3 or 4 topics. The number one was lead exposure and toxicity, which we identified, or he identified, before he took office. And we've been working hand in hand with Mara and other people, including, for instance, Pure Earth, which you mentioned, and other academic settings outside of INSP. And this is definitely something that is high up in the agenda. This very morning, there was the cover of Milenio Diario, which is a nationwide outlet, mentioning the evidence of lead toxicity in children in Mexico, which is nice because they put out there information for a broader audience. Fortunately, Mara and other people like her have been raising awareness within the government for a few years now, and we are working for ways to tackle this. And I think what you mentioned, or you mentioned many things, but one thing that I take, I'm going to take to the secretary, is education. We need to implement strategies to tell people what the sources are. And I think rather than focal actions, in the understanding that most of lead exposure in Mexico comes from how to say, ceramic, from glazed ceramic. Thank you. There are things that I don't know how to say in English, same as you in Spanish. But this is so complex. So, I mean, it's so the intricacies of getting rid of glazed ceramics are complex. I can speak about myself. I inherited the ceramics from my grandmother. My late grandmother left me her baby grand piano and a lot of ceramics, and I still have them. And I know they're loaded with lead, but the reason they're still hanging there in my shelves is because of love, or it brings something. And there are many other silly reasons for people not getting rid of their glazed ceramics. But if we go out and tell people what the sources are, and if we go to the state of Nuevo León and tell people about the recycling and then pollution, air pollution and so on, the beauty is that if we translate that into public policies and information, thanks to Ensanut, we will be able to see what works and what doesn't. And understanding that lead poisoning goes away relatively quickly if the sources are dampened or limited. So this talk raises awareness within the community, but also in the government, and rest assured that we're acting on it, and we'll make sure that we'll work with you and Pure Earth and Bloomberg Philanthropies and whomever is willing to help us. And we're aware, and we want to do public policy. I mean, of course, in the understanding that resources are limited, budget is limited, but we are willing to go into public policy, which probably has a deeper impact. Thank you so much.
Thank you, Ivan. Ana Lucia, do you want to share some thoughts with us? Thank you.
Yes, thank you so much. Yes, just to complement what Sergio was saying before, I think that we have really documented like the majority of the exposure of lead here in Mexico, but as Sergio was explaining before, it's a traditional, complex, social, thing to change. Though our efforts will be there as we have identified that. But as you see, like the rest, like the 50% that it's out there, the other part, it's also complex, no? So I have more of a question of how things are done when you have like different sources, how to target those levels to reduce the blood levels of lead when you have like so complex and many. I think that's other barrier. Like how do you do that when you have many sources coming from this toxic problem? But yeah, definitely we have it high on the agenda, and we will push it with all of the efforts that are engaging in this topic. So thank you.
Thank you so much, Ana Lucia. Do you want to comment, Dan?
I mean, your last question, I think, is one that is the most challenging and the most vexing across the world. I think, in all honesty, I would say that we're not far enough along to know exactly how to do that and what the lessons will be from that. I like to think of sort of sources and I don't know the word in Spanish. In English, it's tractability or mutability, changeability, la capacidad de cambiar. I think of it as a matrix. And so there's a matrix of importance, we think, and the matrix of changeability. And I think that in most cases, the sweet spot early on for early success are the things that are changeable and the things that are probably, of modest, at least modest to higher importance. And sometimes those things are, regulating lead paint. Sometimes that might be getting spices, getting lead out of spices, because that is not a universal phenomenon. It doesn't have a cultural defense to it. It doesn't touch on traditional practice. It's just wrong, and I think people, like everyone, recognizes it. Some things that have cultural use dimensions are more easily changed. We've seen some of that, for example, in cosmetics, or in some of the traditional medicines that women take during pregnancy. They in some parts of the world, there's a clay substance that's thought to basically sort of help with especially early, first trimester nausea. To the extent it has any benefit, it's not because of the lead content of it. And so if we can create a stream where the supply changes. So those sorts of things are very helpful. I would say that lead glaze is sort of in some of the most difficult to change categories because of the cultural dimension, because it employs people, because it's invisible, because to know it, you have to test it. Those kinds of things. Because the supply stream is so diverse. It's not coming from a single factory or maybe it's coming from only a handful of states. That might help. But it's right up there with batteries, recycling batteries. It's a very challenging thing it's easy to regulate on paper. It's very challenging to enforce because it has advocates, it employs people. There are people in communities that don't want to see them shut down because, it's a source of income, that kind of stuff. So, yeah.
Thank you, Dan. Tenemos una pregunta por el Zoom. Quisiera preguntar si aquí en la sala hay alguna pregunta, comentario. Por el momento no. Entonces, voy a leer una pregunta que tenemos por Zoom. Dr. Rafael Lozano asks, thank you very much for this very informative and much needed seminar. What is your strategy for approaching countries? Having them collect data or using GBD results to at least initiate dialogue. In academic terms, GBD works well, but what is the perception of GBD in political terms?
So does everyone know what GBD is? The global burden of disease. It's the University of Washington's estimation scheme in the absence of perfect data. So the way, here's my sense of GBD. The GBD data has been extraordinarily valuable for convincing donors to pay attention to this issue. And I don't think it would have happened without it. When it comes to country level work, I have yet to engage with the Ministry of Health that trusts the data fully, or that will act on it without additional local data. So when the way my organization works is, sometimes we work with a donor and sometimes the donor comes to us. Once we know that we have the ability and the resources to engage a country, what we typically do is reach out to them. We write a brief about lead. Why is it important? Who's at risk? What happens if you don't do anything? What are some of the sources? And what do we think is going on in your country? And it's a very quick summary of the academic studies that have been done, usually on small areas or hotspots. And then we include the GBD numbers. But we do that only to invite a conversation. The conversation immediately turns to the importance of local data. And so I've yet to encounter any country that we've engaged with that does not immediately recognize the value of nationally representative data in a survey. They understand that that's a starting point and necessary but not sufficient to make some change. So GBD has opened the door, but I don't think it's sufficiently actionable without local data.
Thank you, Dan. The importance of understanding the local context to understand sources of exposures. Yeah, of course. ¿Alguna otra pregunta? ¿Alguna pregunta aquí de la sala? Vamos con Livni y luego tenemos otra pregunta remota. Livni, gracias.
Thank you. I was wondering, in your experience, is there any reference towards the lack of education, any experience, positive experience that you have encountered in the world? Because you mentioned that one of the problems is that the medical team or physicians or nurses or the whole personnel that is in charge of dealing with this, once it's detected, we're not trained. So I understand that in Mexico, the agenda for training in medical education is very busy, and probably it would be very good to include this in the agenda. But I understand that also in the other way, for clinicians and for personnel, it's very difficult to manage all of what needs to be learned in preventive issues. So have you encountered any experience globally or anywhere in the world that we can learn from to improve this in our country, which is very important?
Thank you, Livni.
So I don't know that I have enough experience to fully answer the question satisfactorily. I think there's two or more streams that can influence this. One is that when there are national guidelines, it is more likely that clinicians will learn, both because there's an obligation to disseminate them, and as you know from my talk, lead isn't that hard. It's not like learning a new surgical skill or a kind of new laboratory interpretation skill. It's fairly straightforward. So one is I think the national guidelines, there's some evidence that will help. Two is there are different models of disseminating clinical practice knowledge or lead knowledge. Sort of one is like a more universal one, like everyone should know something about it. And the other is to target the right part of the healthcare system. So should it only be pediatricians? In some places, I could make an argument that it should be community health workers as opposed to clinicians, because we know that counseling is really the only intervention for the vast majority counseling on source identification and exposure reduction is the only real valuable clinical interaction. In Indonesia, for example, the model is looking, as now that they've disseminated their guidelines, is that they're trying to create these kind of centers of excellence, like poison control centers, where the clinicians may be guiding a risk assessment, but as soon as anything is flagged, that immediately goes to a center of excellence or a poison control center, and then they manage the case from there. We've been working with a medical student association in Indonesia called CHIMSA, and they have been advocating for the inclusion of environmental issues into medical school curricula, climate, air pollution, and now lead. And I can't speak to how successful they're going to be, but I know that that is a bottom-up approach to try to influence medical school curricula and nursing school curricula. So I don't think we have a tremendous, the last pathway I want to add is that depending on how healthcare is financed and what the incentives are at the clinician or at the institutional level, the other fundamental way to influence clinical practice is to pay for it. And so when testing becomes widespread enough that it becomes reimbursable under a healthcare scheme, if you order a blood lead test, then an institution is going to be much more likely to order that test. When a clinical interaction, counseling a family about lead, is indicated and coded as either a billable service or an expected service, then it will happen. So the economics is we shouldn't lose sight of how that influences it.
Thank you very much, Dan. Let me go to the next question in Zoom. Dr. Cliserio Gonzalez says, wonderful session, airlines industry, worth mentioning it. I think that I will read two. There's another one by Jose Luis Figueroa. Given the challenge of identifying and eliminating sources, what is the potential role of remediation policies? What kind of interventions might or might not work once exposure occurs in the population?
Okay, I might ask you to read that second one again, because I'm not, but I think maybe the question about airlines is intending to identify that leaded fuel is still used for some small aircraft. So perhaps that's what they mean. I mean, I'm sure there's also lead that's used throughout the manufacturing of industry or something like that. But there are still exceptions around the world for some leaded fuels. How important they are at a population exposure level, probably not very. But if you live right next to a small airport where only small airplanes are being, small propeller airlines or airplanes are being used, it could be a significant source of sort of local dust. The second question, sent.
If you read it by yourself, because my English.
Okay. So the question is really about remediation. Like how important is remediation? Because I've talked principally about source elimination and source reduction. And this is an enormous challenge globally. What do you do about lead in place? Especially things like contaminated soil and leaded paint, for example, and contaminated water supplies, although that's much more rare. I think this is a huge challenge. I mean, here's what I'll say a couple of things, and I don't mean to be controversial, but I'll state it. I'll maybe overstate this position for emphasis, which is that the declines that I showed you in population blood lead levels have almost nothing to do with remediation. They have to do with source elimination. Now, that's not fair for the person living on a contaminated site. That's not just for people who are like a small community that's suffering, where the the lag between further contamination and exposure reductions might be very long. But at a population scale, I don't think there's a very strong amount of evidence that that outsized investment in widespread remediation is necessarily cost effective. Now, that said, there are Pure Earth, for example, has done some very good work and is doing more grounded studies on what are some low-cost techniques for remediating soil. For example, there are lots of techniques all the way from soil replacement to soil capping to greening an environment to just covering it, with dust impermeable materials. So those may well turn out to be sort of appropriate, necessary, and cost-effective strategies. The expenditure of funds in the United States to remove lead paint, I think it's very much arguable that it has not necessarily been a cost-effective, wide-scale intervention. Again, I hesitate to say those things because you can't lose sight of the fact that you do not want a child peeling paint. But this is where our sort of public health hat and our human right, our sort of our individual focused hat sometimes collide. Maybe the other thing I would say about sort of paint abatement in the United States, which has been, very costly. If you hire a firm to do what we call lead-safe home remediation, you are talking for an average size home, tens of thousands of US dollars in safe practices and people in abiding by very careful work rules, all to kind of remove lead paint in a way that does not add to the dust, does not add to local contamination, that makes the home safe for kids and that removes it completely. But there are many other sort of interventions to basically prevent it from being at the surface, assuming that the wall is, can handle additional paint, that kind of thing. So I think that we'll learn more over the coming years through some of the investment in some cost-effective remediation strategies, but this is one of those challenges where if you think at a population scale, it's not clear how cost-effective these are. If you think at the individual scale, we want to do everything we can to get lead that's already in place out of the environment.
Thank you, Dan. ¿Alguna pregunta de aquí de la audiencia? Sonia. Y creo que, perdón, ya serían todas porque estamos un poco arriba del tiempo. Gracias.
Thank you for that amazing presentation. My question is, I found very interesting what you said about New York, the monitoring in children's. So I was wondering if you could tell us a little bit more of how this surveillance and monitoring start, and maybe what could be the next step to achieve this for low and middle income countries like Mexico.
Yeah, so as I mentioned, I was the deputy commissioner for environmental health for New York City under two mayors for I think 7 or 8 years, and the lead poisoning prevention program was one of many that sort of reported up to me. So I never ran the lead poisoning prevention, but I was very aware of its work. So the surveillance program in New York City consists of sort of 2 major streams. One is that what I mentioned is that by law, every blood lead test must be reported electronically to the city of New York. Then a unit of epidemiologists within the department, they bring that data in, they clean it, they run it through all kinds of sort of analyses. And the value of the analyses, there's sort of 2 streams. One is to report surveillance findings. What are blood lead levels? Where are they worst? In whom? At what ages? Seasonality, those kinds of things. But the other is to inform sort of case follow-up. So the data then splits into the surveillance team and then a group of people who are responsible for case follow-up. the health department of New York City has direct responsibility for inspecting the homes of children with high blood lead levels. When I first started at the health department, home inspections began at 15 micrograms. I believe they're doing them at 5 or 3 now as well, which is doable because those numbers keep falling. So they receive city tax money to employ a team of 20 or so home investigators. I think that's the number. Maybe it might be higher. They go out, knock on the doors, and they run through a standard protocol. They carry with them a portable XRF machine to test paint on the walls and on the friction surfaces, windowsills, and where they find, using an XRF, lead paint, they use a marker, they mark it in the area where they are, and they issue a violation to the owner of that property. Most people, especially low-income people in New York City, live in rental housing, so they're not responsible. The owner of that building is responsible. That owner then has to do follow-up. They can challenge the results by hiring their own testing firm, or they can develop a remediation plan for addressing the lead paint. And that usually involves expensive lead-safe practices to remove it. The city will not violate a landlord for having leaded paint on intact surfaces, as long as it's not the surface, the first surface, as far as I think I'm remembering correctly. So that's how that works. And then they collaborate with the housing department in New York City, which is not part of the health department. And then they do follow-up on the remediation activities, of the owner. During that first visit, however, they do other things. They ask questions about imported products. They ask about the use of traditional medicines. With permission, they'll look in a medicine cabinet to see if there are any products that have been suspect before. They'll look for imported Mexican pottery, for example, to see if there are leaded glazes. And oftentimes they'll collect materials and then have them tested in a laboratory. And then when there's follow-up, there's always information back to the people. But one of the really great things New York City has done is they've developed a public database of all of the products that they found that are high in lead: consumer products, cookware, spices, cosmetics, etc., and the country of origin, what they know about the manufacturer, and they share that across the globe, but also with other U.S. States and cities, so that in their own investigations, they can look for these things as well. The second kind of surveillance New York City has done, which has been very rare, I think we've only done 2 rounds of it. I was involved in the first. I left by the time the second was done, which was a citywide biomonitoring program, where we collected blood and urine, basically from a representative group of adults and perhaps children in the second round, to test for a whole host of toxicants, but also conditions that are associated with chronic disease. And so we were able, because adults are not tested for lead, we did not know what adult lead levels looked like in New York City, because we only get the only other people who are tested for lead routinely are pregnant women, if their physician is smart enough to ask for one, or certain workers that work in lead industry that are required by law to be tested periodically. So we didn't know what adult exposure to lead, mercury, arsenic, cadmium, chromium, pesticides look like. So we did a representative survey, a biomonitoring survey. So we've done 2 of those. And I don't know whether the city will continue to invest in that, but that's another way we learned about lead. We didn't find it a significant sort of problem with lead at that point. It was very useful for discovering a significant number of people who had very high mercury levels. One group had very high organic mercury exposure, which is measured in blood. And we visited those individuals, and we determined and looked at our covariates, and we determined it was largely based on much higher fish consumption. And then we had very high levels, especially among Dominican New Yorkers and African New Yorkers, of inorganic mercury exposure measured in urine, and we determined that the vast majority of those exposures were from skin lightening creams imported from South Asia and from Africa. And so we did a lot of work to get those off the shelves. Does that answer your question? Was there another part to your question? Oh, what can other countries do? So I think the most important thing is to start with a representative surveillance study, and then the findings of those should be used to justify, ongoing expenditures. It could be done every 3 years. It could be done. It could not be done necessarily nationally representative in the future, but you can develop a passive surveillance system off of it where the country collects blood lead levels that are tested. You could develop a sentinel surveillance system off of it where you pick, institutions in areas where you have limited testing, but you have higher blood lead levels, and they become a sentinel site for you, so that with a limited number of tests, you still get longitudinal data that is illustrative of trends. Those are some of the possibilities.
Thank you, Dan. I think that we are over the time. So no, please don't be sorry at all. We are sorry. Pero pues muchísimas gracias por su presencia, tanto las personas que asistieron de manera remota como las que lo hicieron presencialmente. Les agradecemos muchísimo su interés, porque solo así podremos juntos ir avanzando en este problema que es grande, pero estamos trabajando. Pues muchas gracias y buenas tardes. Gracias a las personas que se conectaron por Zoom. Hasta luego. Wow.